for that, for the support. And my talk is about the future. As you all know, Dr. Paul Webster is a founder of APA. And according to the record, he organized the first formal annual meeting of APA in 1978. And he studied on the effect of fasting, feeding, and stimulation with CCK on the pancreas. And this is my mentor, Dr. Philip Rayford. We studied on the effect of diet on CCK-stimulated amylase secretion by pancreatic arginine and amylase messenger RNA levels in rat pancreas. So in a sense, we are working in the same field as that of Dr. Webster. I also would like to refer to a mentor of Japanese surgeons, Dr. Ichio Honjo. He is also a founder of JPS and professor of surgery at Kyoto University. And he performed the first right lobectomy of the liver in 1949. And he has proposed and advocated total pancreatectomies for the treatment of pancreatic cancer because he found many loci of carcinoma in situ in the rejected specimen of pancreatic cancer. And this has led to another collaborative study about the precursor regions of pancreatic cancer. You can find Drs. Ruban, Longnecker, Alban Maitra, who have been the leader of APA. So pancreatic cancer is a highly lethal disease. We all know that. And we have believed that surgical resection is the only chance for cure. This is a central dogma. However, do we really know whether or not surgery can save patients with pancreatic cancer? Do we have any evidence that surgery is superior to other treatment? 20 years ago, when I was young, my mentor, Professor Imamura, conducted a study of a randomized multi-center trial comparing resection and radiochemotherapy for resectable pancreatic cancer. As you can imagine, it was very difficult to recruit a patient to this trial because the patient knows that they have resectable tumors. But we have somehow recruited 81 patients, and eventually 42 patients was randomized to surgery and radiochemotherapy. And as a result, the surgery was superior to radiochemotherapy, and I have enrolled one of my patients. Unfortunately, he was assigned to surgery and lived longer than 2 years. And the surgery can elevate the survival curve. But this kind of improvement can be achieved by modern chemotherapy, such as FOLFIRINOX. But the value of surgery lies here, the long-time survivors. However, long-time survival is only 10% because, as my friend Dr. Kamisawa has already shown in 1990s, 90% of pancreatic cancer patients are metastatic. So the diagnosis on imaging is like 40% local regions and 60% metastatic regions, but in reality, only 10% are truly local. And there are a lot of treatment options, and they vary from countries to countries, as you can see here. And we have already shown that the guidelines, European guidelines, American guidelines, Japanese guidelines are very much different because of the evidence, because of the understanding of the evidence. Recently, Dr. Unno and his group has conducted a study to compare neoadjuvant chemotherapy and upfront surgery. And they have shown that neoadjuvant chemotherapy can prolong survival by 10 months. So neoadjuvant chemotherapy for resectable pancreatic cancer is becoming standard of care in Japan. And actually, we are revising the guidelines of JPS. And very soon, the revised version will be published. So in a sense, we have already shifted the gear. So in the past, neoadjuvant therapy had been offered to borderline resectable pancreatic cancer or some local advanced pancreatic cancer. But in the future, or from now on, neoadjuvant therapy or induction therapy can be offered to all kinds of patients, resectable, borderline resectable, or even unresectable patients. I'm also very much enthusiastic about radiotherapy. And we use IMRT, but we have to be very careful when we use this kind of very strong radiation therapy to avoid complication after surgery. After chemoradiation, we see a lot of fibrosis. So actually, this is an example of artery-first approaches for pancreatic cancer. As you can see, there are a lot of fibrosis, and we have to struggle with this kind of fibrosis after chemoradiation. But with this technique, the surgery can be achieved much more safely. And for the robotic surgery, artery-first approach is very beneficial. Of course, I'm aware that there is a concern about the safety of minimally invasive surgery, but we cannot go back. Remember your car, it is no longer manual. Everything is automatic. The computer is controlling your car. And this is a retrospective cohort at my institution, the borderline resectable pancreatic cancer. So neoadjuvant chemoradiation appears to be a little bit better than neoadjuvant chemotherapy, but in reality, neoadjuvant chemoradiation can offer very good local control, but it ends up a lot of distant metastasis, especially peritoneal dissemination. That is why the survival benefit is minimal. We have to remember that 90% of pancreatic cancer is metastatic. If we cannot treat those 90% of patients, we can never improve the survival. Recently, Dr. Honjo of our university and Dr. Allison of Emily Anderson Cancer Center have received the Nobel Prize. They introduced the immune checkpoint inhibitors to cancer therapy. Dr. Honjo discovered and sequenced PD-1. And there is a very interesting phenomenon which is called abscopal effect, combination of systemic administration of PD-1, PD-L1 inhibitors and radiation therapy to the main tumor and selected metastatic region can control other unirradiated metastatic regions. And this is already confirmed in other solid organs like lung cancer or prostate cancers. So I'm hoping with a good combination of effective radiation therapy or maybe anti-stromal therapy, those immune checkpoint inhibitor can exert abscopal effect. I'm aware that some of the American colleagues are working on this. Maybe, Carlos, you are involved, I guess. And we are also going to work on this. And in the future, the majority of pancreatic resection for pancreatic cancer will be carried out after neoadjuvant therapy. Indication for pancreatic resections for pancreatic cancer will be expanded, resulting in technical challenges for surgeons. Innovation in surgical techniques such as artery-first approaches are needed. And for better survival, it is essential to develop new therapeutic modalities to control the metastatic regions. Immune checkpoint inhibitors in combination with RT and other drugs are promising candidates for the treatment of metastatic diseases. Yesterday, Margaret's colleague has kindly given me a ride to Haleakala Mountain, and then we enjoyed the very beautiful sunrise. And we have suffered from a nightmare of pancreatic cancer without significant improvement in cure for these 50 years. However, I hope this is a prime time to change it, and I hope the sign is rising. Thank you very much for your attention.
Thank you very much, Professor Tagore, for your promising points for the future of pancreatic cancer treatment. So we are finishing this session. Thank you very much. But I would like to ask the speakers kindly come to the screen of the birthday screen to get the memory credentials of the APA. Professor Ashok Saluja put behind us the plaques. Is it correct? For getting
in front,
pictures,
down in
yeah?
front. Okay.
Huh?
And Margaret can come and take a